international trials. He recently authored the American College of Gastroenterology Clinical Guidelines, Evaluation Abnormal Liver Chemistry, and his talk is Special Consideration in NASH for HCC Risk. Please come.
Thank you, and good morning. And I appreciate the kind invitation for this wonderful meeting, and we looking forward to an exchange of ideas. As you will see after this lecture, we all struggle with the same challenges. So we're going to talk a little bit today about special considerations in NASH for hepatocellular carcinoma. So Dr. Hamid has already given us this wonderful overview, so I have to spend very little time on this, other than NAFLD is prevalent, as all of you know. And the important thing that he also stated, which I can't emphasize enough, is NAFLD intermingles with all the other diseases we see, be it hepatitis C, be it hepatitis B, it's everywhere. And so we all have to be extremely careful as we assess our patients. So I would just like to give you a typical patient that we see. This was a 67-year-old male who presents for evaluation in your clinic, sleep apnea. He's had a myocardial infarction and diabetes. He's on a variety of metabolic syndrome medications, and you can see his BMI is 33. He has some central obesity, but no discernible hepatosplenomegaly. Platelet counts 140,000, AST, ALT 65 and 70, bilirubin normal, albumin 3.5, elastography 13 kilopascals, ultrasound, heterogeneous liver, and mild splenomegaly. And that was the assessment. And so, of course, the question would be, what would we do for this? And would we simply counsel lifestyle modifications and follow him? Would we do this and begin screening him for hepatocellular carcinoma? Will we counsel lifestyle modifications, follow up with him, and then begin surveillance? In this gentleman, if he doesn't improve, would you biopsy him? Or in the US, we use magnetic resonance imaging sometimes when we're not quite sure about the level of fibrosis. And these are the contexts, this context is what we struggle with in our clinics each day. So in the world, you can see here that dominant drivers of hepatocellular carcinoma are viral hepatitis, and that still counts for most, but metabolic syndrome is growing, and toxins in other parts of the world. And this very nice review that was published last year in in Nature Review, showed that there are parts of the world now where NAFLD is really dominating HCC, and in particular, India is probably the highest right now for HCC related to NAFLD. The UK is probably not far behind, but I suspect systematically in Pakistan, you will probably find similar prevalence. And just based on my observations rounding yesterday, you struggle with the same things we do, in that there's so many individuals who don't know they have NAFLD. The other important thing is that, we always have said cirrhosis is a precancerous condition. So if you have cirrhosis, you screen for HCC with an ultrasound and an alpha-fetoprotein. But the problem with NAFLD is that there are now multiple series, as I'm going to go through, that have shown us that HCC is quite prevalent in those with NAFLD without cirrhosis as well. And again, the problem for this is that, again, we don't have great denominators depending on how you define NAFLD, be it with a CAP score, be it with an ultrasound showing fatty liver. And so we have to be very alert in our clinics when these patients come through. And right now in the US, NAFLD is the third most common cause of HCC, but it will become the dominant cause over time. And again, the concern here is that we don't typically screen those with NAFLD routinely for hepatocellular carcinoma unless we think they have cirrhosis. But you can see here, I'm going to go through some data here that shows that the number of NAFLD HCC cases is rising. And the most disturbing part of the presentation is when you present with HCC and NAFLD, you typically have worse survival. And this was a study from Zobair Yanasi that was actually now 7 years ago, which showed that fewer HBV HCV patients, which in the US were the groups that we always considered as having the highest mortality from HCC, actually they presented and they had better survival. And again, likely because we recognized their liver diseases ahead of time. And when HCC arises within a NAFLD liver, often these tumors are big, bulky, and oftentimes the treatment options can be somewhat limited. We know NAFLD causes cirrhosis, but NAFLD is also associated with hepatocellular carcinoma, and this was based on a very nice database study in 18 million Europeans, an electronic health record that showed that there was actually quite a strong association with hepatocellular carcinoma in those with NAFLD. And again, this study, which comes from our VA system in the United States, showed that in the Veterans Administration, NAFLD, again, without cirrhosis, caused more hepatocellular carcinoma than did hepatitis B. And for the fellows who are here, they know that when we are trained to screen for hepatocellular carcinoma, with cirrhosis we screen for HCC with ultrasound and AFP. The problem is when you have a quarter of the world's population with NAFLD, then it's impossible to get ultrasounds on a quarter of your population, right? It's just not practical. And so we're going to have to develop better algorithms to do this. And again, this just shows here the HCC incidence is estimated in per 1,000 patient years. And you can see for cirrhosis, it's 10 to 15 per 1,000 patient years. For NASH, it's lower. But for NAFL, that is non-alcoholic fatty liver disease, it's lower, except again, this pool here is probably 20% of the world's population. And because so many people have NAFL, the challenge is how do we find these hepatocellular carcinoma patients here without going in and screening large numbers of people? There aren't enough liver doctors, gastroenterologists in the world to take care of all of these NAFLD patients who might be at risk for hepatocellular carcinoma. And again, this was an additional study from the U.S. that actually also confirmed that NAFLD, in the U.S. at least, seems to be the most common cause of hepatocellular carcinoma in those without cirrhosis. Just regarding the contribution of NASH cirrhosis, NAFLD, and NASH to hepatocellular carcinoma, you can see here, this is the HCC prevalence from 2002 in our UNOS database. In other words, those that are registered to get a liver transplant, and there is no question that NAFLD-related HCC is driving the rise in HCC registrations. So again, we will hopefully by 2030, or maybe shortly thereafter, have made a major impact in viral hepatitis, both through diagnosis and treatment. But we need to do this because of all of the hepatocellular carcinoma that is going to be out there from non-alcoholic fatty liver disease. And again, this just shows, this is Zubair Younasi's paper here. And if you look at these pie charts going from 2002 on the left over to 2017 on the right, what you see here in lavender in the top right is NASH. So in 2002, NASH was 2% of all the hepatocellular cancers. By 2007, 8%, 2012, 12%, and by 2017, 8% of the hepatocellular carcinomas. And like I said, over time, viral hepatitis is going to subside, and NASH-related HCC is going to take over. So what does this mean when we look at other parts of the world? We're seeing exactly the same patterns, and these are studies that come from the US and Europe, all showing that HCC-related NAFLD is going up. And in the US, we know that now NAFLD is the most common indication for listing for liver transplant, followed closely in the US by alcohol and viral hepatitis, which was driving our hepatocellular carcinoma and transplant practice. Now, at least in the US, hepatitis C is no longer a leading cause of liver transplant, and I hope with the successes that you have implemented here, or programs you've implemented in Pakistan, you will have similar success that we have as well here. So what about these liver cancers when you develop them in the setting of non-alcoholic fatty liver disease? The problem is that oftentimes these tumors are bigger and bulkier. Why? Well, because oftentimes they're not diagnosed with NAFLD yet, and they present with right upper quadrant pain. Something that has been quite interesting that we have seen is that you get these large single tumors with non-alcoholic fatty liver disease, and these are without cirrhosis, and essentially no known liver disease. Patients just present when they just get significant pain or they turn jaundice, and oftentimes we believe that these tumors likely arose perhaps from hepatocellular adenomas, again, as a result of non-alcoholic fatty liver disease. But these are all going to be important registries that will need to be assembled worldwide as we try to better determine, prove biomarkers to screen individuals with NASH and non-alcoholic fatty liver disease. So let's go through the characteristics of non-cirrhotic hepatocellular carcinoma and NAFLD. These are well-differentiated cancers. They're bigger. They're not encapsulated. And the tumors arise in a background of steatosis. And what has been striking about this is that steatohepatitis need not be present for this to develop for hepatocellular carcinoma. And as I said, these two well-differentiated tumors, some believe actually are arising from hepatocellular adenomas. At least in the United States, what we have seen also with our NAFLD patient is more hepatic adenomatosis as well. Particularly in women, we've seen women present with multiple adenomas, and it wouldn't surprise me if ultimately our NAFLD related HCC patients, that's the pathway that is leading to all of the increase in NAFL-related hepatocellular carcinoma without cirrhosis. We know obesity and diabetes. We've just heard a very nice lecture about some of the mechanisms in the development of NAFLD. These same comorbidities drive probably development of pre-neoplastic and neoplastic transformational change in non-alcoholic fatty liver disease. Obesity and excess of adipose tissue all lead to a general low-grade inflammatory response, and these pro-inflammatory cytokines likely activate a variety of pathways, including the Janus kinase pathway, which is important in the development of hepatocellular cancer. In addition, NAFLD patients are insulin resistant, right? So insulin is there, and as all of you know, insulin and its cousin, insulin-like growth factor, are all activate potentially oncogenic pathways. You know, if you're constantly stimulating your growth pathways, you can activate some of these, and these unfortunately can lead again to neoplastic change. We know the lipotoxicity that's associated with non-alcoholic fatty liver disease from the lipid accumulation. The excess insulin causes triglycerides to go into the liver, which sets up this inflammatory response. And typically what happens with these free fatty acid oxidation reactions, you generate these reactive oxygen species, which leads to cellular damage, and again can potentially, in the setting of all these other metabolic derangements, lead to cellular damage and potentially neoplastic change. And finally, as we just heard, clearly the microbiome is going to play an important role in the generation of these hepatocellular cancers, and we're going to need to get better data on just what are the true gut dysbiotic patterns that associate with increased lipopolysaccharide levels and generate additional cellular damage that can raise your risk of hepatocellular cancer. So what do we know now? So we know now that there are some modifiable risk factors for hepatocellular carcinoma in those with NAFLD. So diabetes, we should be managing aggressively our patients with diabetes. In the United States, weight gain is a big challenge for us. We have bariatric surgery, and we also have certain agents now, which I'm not sure are widely available in Pakistan, but we have these GLP-1 agonists, which do seem to reduce weight more effectively than other therapies that we've intervened with. And all of these can reduce obesity, can reduce insulin resistance, and improve control of your metabolic syndrome. There are also factors which are fixed, and of course, we know that those of Hispanic ethnicity are at higher risk for NAFLD. There are genetic polymorphisms now that are being identified. So some of you know one of the first ones that was reported with severe NASH was PNPLA3, and it's not surprising now that PNPLA3 is also the strongest genetic polymorphism that's been associated with NASH-related HCC as well. And you can see here there are a few others that have been reported. Again, this isn't surprising, but TM6SF2, and I have there are a few more polymorphisms there on the third box from the bottom, which are all reported to raise the risk of NAFLD-related hepatocellular carcinoma. Obviously, dietary factors and smoking are an issue, and as well as controlling our lipids. But all of these come together and contribute to the rising rates of hepatocellular carcinoma that we're observing. So what do we do right now? So our own AASLD guidance that we adhere to says that we should screen populations at risk that include cirrhosis, and again, this is cirrhosis due to non-alcoholic steatohepatitis, in addition to hepatitis B, hepatitis D, and again, hepatitis B in non-cirrhotics. We recommend an ultrasound, which is problematic in NAFLD patients. We typically have our own ultrasonographers here, as I understand it. Many of the hepatologists and gastroenterologists do their own ultrasounds, but you know, an ultrasound in a NAFLD patient can be problematic in quite a few of these individuals. And for those that I am screening, even with cirrhosis, I try and sneak in a CT scan or an MRI at least once a year, just because it is just very difficult with a severely steatotic liver to see the liver well and pick up small focal lesions. The alpha-feta protein I use, it's optional in our practice guidance, and there is no recommendation for non-cirrhotic NAFLD with regard to HCC screening. What about the EASL guidelines? They're a little bit more flexible here. So it's cirrhosis, and it's also NASH with F3 fibrosis, including F3 fibrosis diagnosed by elastography. Our own AGA, American Gastroenterologic Association, recently released a clinical practice guidance where they actually took a similar approach, which was screen NASH patients with cirrhosis. We can all agree on that. But we're also going to screen those with evidence of advanced fibrosis if you have 2 non-invasive tests. So this could be a FibroScan, it could be something as simple as a FIB4, and with those you should enroll them in cirrhosis, hepatocellular carcinoma surveillance programs. What we're ultimately going to need to do is we're going to have to risk stratify all of these individuals whom we see in our clinics. These include looking at the demographics, the comorbidities, the genetic factors. We're going to have to try and work with them to modify their diabetes and metabolic syndrome medicines. So, for instance, we know metformin has been associated with a reduced risk of hepatocellular carcinoma. Statins and aspirin have been associated with a reduced risk of hepatocellular carcinoma, and we'll probably be prescribing some of these in addition to other therapies to try and reduce weight and reduce insulin resistance. We're also probably going to be looking at some of these polymorphisms as well. And as I said, PNPLA3, amongst others, are going to be, I think, become more widely available and will help us risk stratify these individuals. But NASH is a complicated disease. And so we have, for instance, for hepatitis B, we have a variety of risk calculators. There are so many factors associated with the hepatocellular injury in NASH that my opinion is we're probably going to need machine learning models to help us really get at what the truly accurate ways to predict who's at increased risk for hepatocellular carcinoma with NAFLD, as well as those with NASH and cirrhosis. But we'll wind up stratifying these individuals, and I would not be surprised in 5 to 10 years if we have a tailored approach to screening these individuals for hepatocellular carcinoma, again, based on a variety of environmental, clinical laboratory tests, polymorphisms, and comorbidities. So, again, what I typically do is I typically see a patient with NAFLD. If there is anything, in my opinion, that is contributing to this person having advanced fibrosis, even if it's one non-invasive test, for instance, if you get a elastography score that may say stage 2 to 3 fibrosis, but the platelet count is low, I generally do ultrasounds on those individuals twice a year. And I go ahead and screen these individuals, but there's still a wide range of patients in my practice who I don't screen for HCC. Some of them have developed HCC, and we obviously need better biomarkers. So in summary, NAFLD is the most common liver disease worldwide, and NAFLD-related HCC is rapidly rising and will become the leading cause of HCC in the world. It probably already is the leading cause of HCC in parts of the world, including perhaps India and the United Kingdom for now. Again, it arises in cirrhosis, steatohepatitis without cirrhosis, and simple steatosis. It's obviously strongly related to the obesity epidemic. Again, screen right now cirrhotic NAFLD patients as well as those with advanced fibrosis. I don't think that's controversial anymore, and I look for every opportunity to have our patients who have NAFLD, if appropriate, go on statins, aspirin, anything to reduce the risk. We obviously need better biomarkers and risk calculators to identify those with NAFLD who are at risk for hepatocellular carcinoma. And in this particular disease, it's very early, and hopefully in the next 10 years, we'll have substantial contributions that will allow us to reduce the morbidity and mortality in this very, very large and growing population. Again, thanks so much for the kind invitation to speak, and I will stop here.
Thank you very much, sir. It's nice, very nice talk.